I'm quite aware that trying to cover critical appraisal in 45 minutes is pretty tricky, and normally we'll give a full course to this type of thing. So I'm not going to cover everything, but what I'm going to try and do is just give you some tips that you might want to take on board for the station that you're going to come across. Because I think once you've got a plan in your mind as to how you're going to do it, you should all be absolutely fine doing this. A lot of what I'm going to talk quite a bit about statistics as well, because I think that's really important in looking at critical appraisal and looking at results, so that you can give your views on it. So let's get going.
Mr. O'Hara,
yes.
Can you hear us? First of all, thank you so much for doing this session. Are we going to get the slides from your talk, or do we need to make notes? Thanks.
There's nothing in my slides that I can't share with you. If you want me to email you the PowerPoint, I'm very happy to do so. I wouldn't make too many notes. You know, you can a lot of this is fairly informal slides that I've written, and you'll be able to find much better sources to read. I mean, if you Google anything about how to critique a paper, you'll get quite a nice summary of how to do it. But I'm just trying to give you some thoughts and tips that I've come across along the way, if that's all right. But yeah, very happy to send you the slides, and you can disperse them as you see fit.
Thank you.
So first thing to say, my top of my slides, and if missing, right, is get this might seem easy, but get the basics right. Now, you're going to come to an interview, and whoever's there interviewing is going to ask you some questions. I have seen in some interviews candidates expecting what the question is going to be. We live in a world where things are so fair that most of you are going to know what the questions are for the stages. People will have shared them before, they'll be published. You'll know what you're likely to get asked. But that can help, but it can also be a hindrance. And I've seen people in interviews expect a question, and then they haven't listened to the actual question that they've been posed, and then they've missed the point on the critical appraisal. So do listen to listen to the question, and for each, as with every station that you going to get in your interview, balance the length of your answer with some degree of common sense. You don't want your answer to be so short that the interviewer then has to prompt you to continue. But likewise, you don't want to go on for 10 minutes and use up the entire station on your opening question. So try and get the balance about right. The interviews that we do, perhaps for more academic positions, but still at your sort of level that everyone's at here tonight, you might get a question such as, can you summarize the trial design and key findings from this publication? And you've got to try and balance that. I'm just going to, all of us, whenever we've read a paper, we want to give our opinions, don't we? That's the whole point of reading it. What difference is it going to make to us? I would keep your opinions until the end of the answer. Do everything else systematically. And then it's probably safest to say, rather than tearing a paper to pieces, perhaps, maybe give a nice balanced ending on it and say whether it will change your practice or not, i.e. what is the impact, what's the value of the manuscript that you've just read. So that's a sort of opening gambit there, really. It's quite useful to you. It'd be quite useful for you to sort of gauge what type of paper you've got. If you've been given a large multi-center randomized control trial that's been published in a high impact factor journal, say the Lancet or the New England Journal of Medicine or the BMJ, and you may well get them. You may well get some, the type of things I've seen given out are big COVID studies, there was a lot of those, and actually you might think, well, what's the applicability of those to ENT? And some of them were around steroids or not for patients with symptoms with COVID in hospital, and these are well conducted studies. But look, if you get a big study like that, and that's probably the sort of thing you could expect to be given is a well conducted study. There's reporting guidelines for them. And you could just have a quick look at what those reporting guidelines are. So if it's a randomized control trial, everybody submitting papers for that has to fill in a consort checklist. And that really means that any clinical trials like this are reported in a set fashion. All the results and the methods are going to be in the paper exactly as they should be, in a set order. And actually, there's even consort checklists for the abstract. So even the abstracts are going to be reported really well. So you don't need, if you get a good study like this, you don't need to go hunting for anything that's hidden. It's all going to be there for you, nicely set out. I suppose the other option is that they could give you a slightly less high standard paper, let's say more of an observational study. And there may be some flaws in it that you may need to pick up and then give a balanced opinion on the strengths and weaknesses of the study. So I think you'll get one or the other. I don't know which way they'll do it, to be honest with you. So let's go through some little bits to think about then. Let's assume you've got a clinical trial. Now, the population is a really important point. I'll show you a picture later about the population and how the sample relates to the population. But let's say, an area of interest for me is patients with globus sensation in the throat. How many patients with globus sensation in the throat come to secondary care? Probably about 60,000 a year in England. So if we want to do a clinical trial, we can't look at all 60,000 of them. We're going to look at a subset of that population. And when you're choosing the type of patients that you're going to look at, you have to think, well, is this pragmatic? Is it reflective of the population that all the other clinicians reading this are going to be interested in? So what's the setting? What's the population? Have the authors who've ran the clinical trial thought about this? And have they chosen a sample that is reflective of the population that you're interested in? And that's where the inclusions and the exclusions come in. Do you think they've been overly tight? Do you think the study population is not reflective of the population that you're interested in as a clinician? This is a good starting place to look at. What are the aims and objectives? So all good studies should lay out exactly what they want to do. Good clinical trials are well designed, and then they conduct what they say they're going to do. Always be a little bit suspicious about a clinical trial that said they're going to do something, but then actually report something else, and they don't report what they're going to say is what they've said they're going to do. So this is probably more important for project write-ups than it might be in papers, but what the difference between aims and objectives. Aim is what the project intends to study, and objects are how you're going to meet that, what you're actually going to do to meet your aim. So these should be laid out. These are the type of things that you want to look at in the methods when you're going to come and think, well, how am I going to summarize this paper in the station that I've got coming? A lot of what you're going to do is succinctly describe the methods. So what's the trial design? Is it a randomized control trial? Is it an observational cohort study? Is it a retrospective case series? The headline statement of what the trial design is really important, so that the interviewer knows you understand that. What's the setting? Is it done in primary care? Is it patients at home questionnaires? Is it in secondary care? Is it in ENT? Is it in speech therapy? Is it on the ward? Is it in emergency care? All of these things are important to work out where the trial's set up. What are the interventions? They should be very clearly explained so that they're replicable. The process of randomization, if it's randomized trials, should be clearly explained, as should the blinding processes if it's blinded. So, is it double blind? Is it single blind? Is it open label, i.e. doctors and patients know what treatment, they can see the treatment? Who's funded it? This is important. So is the funder an independent funding body, such as the National Institute of Health Research, which is our UK clinical funder, or has it been funded by pharmaceutical companies? So you might want to look out for some of the work that we've done. The first trial that we published on proton pump inhibitors was published by the NIHR. Our upcoming trial, which is looking at alginates, has been funded by the makers of Gaviscon. Now, actually, the makers of Gaviscon are completely independent to how we run the trial, but they're a funder of it, and that's a conflict of interest. So have a little look at this and ensure that the reporting is independent to the funder. Check that the ethics are correct. You know, anything that we do, if we're doing anything over and above normal practice on patients, we need ethical approval for that. The one area that we probably don't is if we've done patient and public involvement, which is very different. Patient and public involvement is really, really important in trial design these days. It's to show that we as doctors have involved patients, have involved the public, have involved stakeholders in the design of our study. And any of you who've done this will find that it's always fascinating to get patients' views. They always come up with something that you just hadn't thought of. We as doctors think we know what patients want, but in general, you'd be amazed by how many great nuggets they come up with to help you design studies. So for a lot of journals now, this is an obligatory part of the methodology to explain how the patients and publics are involved in the method design, and if not, why not? So you should be able to summarize that quite succinctly. I'm not sure you need to really, for the purpose of your exam station, you probably don't need to go into too much detail about the funders and the ethics, but for the sake of a few words, it looks good if you do. Now, the outcomes, these are really important, and these are often the difference between well-conducted research trials and those that aren't, because the less rigorous clinical studies may have somewhat wishy-washy outcomes. If you're designing a clinical trial and you are setting out exactly what your analysis plan is going to be and a protocol and exactly what you're going to do, you're going to have to specify what your outcomes are. And you split them in terms of primary outcome and secondary outcomes. And the primary outcome really is the important question that you're trying to answer. That's the whole basis on which your results are going to be based and what you're going to draw your conclusions from. It's also the basis of how big your study is, what's the sample size. Your secondary outcomes, generally, yes, they're there to support the primary outcome, but you may have a whole host of secondary outcomes in there that you'll report. But let's say, for instance, you run a trial and your primary outcome, you find that there's no effect of the intervention, but you do on the secondary outcomes. I don't know if any of you have read much in terms of sleep disordered breathing trials in children. There was quite a well-known study a few years back called the CHAT study, and that looked at adenotonsillectomy in kids for OSA. The primary outcome was a really complicated neurophysiological assessment of children. And in the secondary outcomes, they contained some patient-reported outcome measures. And the trial was a negative trial. So adenotonsillectomy did not improve neurophysiological outcomes in children. And now you might say, did we choose the right? It wasn't a study that we ran. I think it was a USA study. Was that outcome the right one to choose? And there's a huge amount of thought and research goes into actually what the outcomes are, how applicable the outcomes are to our patients, and actually what matters. So when we ran the adult tonsillectomy trial, our primary outcome was the number of sore throat days. Patients either received a tonsillectomy or they received conservative management. And the primary outcome was the number of sore throat days that they'd had over 24 months. That's the highlight in terms of what we report. We also looked at quality of life, specific tonsillitis quality of life, general quality of life, but these were all secondary outcomes. So you report them as such. So just make sure if a trial's saying, this is our primary outcome, this is the sample size based on our primary outcome, that they report it as that. You'll be amazed how many times you read them and the primary outcome isn't specified and it's not the first thing that's reported in the results when it should be. I hope that makes sense. So know about outcomes, think about them, have the outcomes that the team have chosen. Do they seem correct for you? Now, there is a core outcomes initiative, the COMET initiative. So if you look at that and you put in any ENT disease or symptom, you'll find whether someone's done a COMET initiative to define what the type of outcome should be. And this is trying to help people who design clinical trials pick the right outcomes for certain diseases. But you've got a variety of outcomes. So are outcomes objective? So you could look at, if we were looking at cancer trials, then survival or events of recurrence. That would be an objective measure. If we were, let's say we were expanding our interest in tonsillitis, we might say, well, you could measure how many courses of antibiotics patients have had. These would be objective. What about hearing? I'm not an otologist, but we've done some research in this area, and it's always interesting to hear what people's views are about audiograms. Is an audiogram objective or is it subjective? Not sure, but it's a measurable outcome. And they differ to patient-reported outcome measures, which we see an awful lot of these days, which are really, really important. Validated patient-reported outcome measures. You see the term validated written a lot for these, but I would think, if you look at what validation of patient-reported outcome measures and questionnaires mean, there's actually a huge amount of research that goes behind these things to look at response to treatment, rate of reliability, reproducibility of the scores. That there's lots of elements of measuring a patient-reported outcome measure to ensure that they are validated. You know, are they reported on patients with the disease? Have they been checked on patients without the disease and controls? So worth thinking about that. I don't know whether you need to, I'm perhaps going into a little bit too much detail here for what you need to do, but I think it's just giving you some idea of how you might look at what the methods are and what's been reported. We'll come on to minimum clinically important difference later when we look at sample size calculations, but it is important. For some PROMs, enough research has been done to demonstrate what is a meaningful difference in the score. So for our septoplasty trial that we're writing up at the minute, these patients were randomized to septoplasty or medical management, and we used the SNOT 22 for that. Now, if you look into the SNOT 22, yes, it's mainly a chronic rhinosinusitis PROM. It has been used in septoplasty, but the minimum clinically important difference has been defined as 9 points. So that's helpful. What do we mean by that? Well, it's all well and good doing a clinical trial and showing that there's a difference, but is the difference enough for us as clinicians to feel that the intervention is worthwhile considering? You know, what would make us want to consider bringing that intervention into our practice? I hope that makes sense. Symptoms, quality, there's lots of different type of outcomes to think about, but look at what they've done. Right, I'm going to move on to a little bit of statistical analysis. And I'll say right from the outset now, before we go through these next slides, I think the biggest mistake any of you can make in this in this station, if you were to do this, is misinterpret what p-values mean. I hear an awful lot of people getting this wrong. You know, you hear people say, oh, well, the p-value was almost significant, or if we'd just done a few more samples, we might have got the p-value below 0.05. That's missing the point of what risk and estimation really is in this setting. So let's go back to what I was saying earlier on and assume you've got a reasonably conducted clinical trial. If you have, and the statistical team on board, they will have produced a statistical analysis plan before the trial started. They'll have set out what they're going to do, and you can assume that the statistical analyses that they've done is fine. And you probably don't, I wouldn't waste too much of my time trying to pull the statistical analysis apart in a well-conducted study. But let's say, for instance, you get a slightly less well-conducted observational study. You may want to look at this area and just see whether you think you agree with how it's been conducted. One thing I look for is look out for multiple separate statistical analyses. Let's say somebody's taken a whole pile of measures on a set of patients and they've reported them all as multiple t-tests. Well, if you've based your level of significance at 1 in 20, 0.05, 1 in 20 of them will be significant just by chance alone. And this is this understanding of chance. Have a look and see whether you agree with whether parametric or non-parametric analyses have been done. Parametric analyses should be on data that's normally distributed. And if parametric analyses have been done, you want to see some demonstration that the authors have proven that the data is normally distributed. And there's various ways you can do that. You can do something just as simple as plotting out the data as a bar chart with an overlying curve, or you can do others. You can do some kurtosis and skew calculations, but they should normally make that clear. This is another really simple but important area to look at: mean versus median. Now, it's and it makes a big difference, and most people will tend to err to using the mean in observational studies, but just have a little look and think whether it's applicable or not. If you've got normally distributed data and the data is symmetrical, then the mean and the median are going to be roughly similar. But if it's skewed, they're going to be different, and you're best to use the median. Now, this is a slide I wrote 15 years ago when I was a registrar, so I could produce this type of thing. So you see it says SPR there. So just to demonstrate this, look, I'd looked at the number of days sickness. I'd completely made this up, but look, you know, let's plot out the number of days sickness that ENT registrars had that year. If you look at the mean, it makes it look like we're taking almost a week of sickness off. But if you look at the median, it's 2 days. Whereas if you look at the annual leave, there's my point. It's a symmetrical distribution, so the mean and the median are roughly the same. And this does make a difference when you actually come to analyze this. I've done this myself with quality of life outcomes that we looked at in early laryngeal cancer. And initially, when we broke the quality of life scores down, if you looked at it in terms of mean, it looked like there was a difference between the patients that we treated with laser surgery and those that we treated with radiotherapy. But actually, when we changed it and said, actually, this data isn't normally distributed. The other thing to point out as well is questionnaires. If you've got a questionnaire and you're asking someone to score, let's say, how much trouble have you had with your voice on a Likert scale, 1, 2, 3, 4, 5? Unless it's very difficult to say, well, a jump from 1 to 2 points is the same as 2 to 3 is the same as 3 to 4. And that's where using parametric analyses becomes quite challenging, and especially if you're looking at individual questions. So when we looked at this, that we were looking at with laryngeal cancer, and we changed it to medians, we found that there was no difference between the laser group and the radiotherapy group at all. So it does matter, and it makes a difference. For those of you who are interested in medical statistics, and I would suggest all of you try and get a little bit of a handle on this, because it really does help with critical appraisal, and it helps with thinking about how you might design research questions or how you might conduct them. Spread of data is important, and we'll move through this a little bit. Variance, standard deviation. So if you have a normal distribution, then 95% of observations are going to be within 2 standard deviations of the mean. I'll try not to bore you too much, but this is the key point I was raising earlier on about the sample that people have chosen for their research project and what the population is. So as I said, we can't study the whole population. So the sample that we've taken is trying to represent the population. So all of the values and figures and statistics that we have for the sample are an estimate of what the population is. The bigger the sample, the tighter the estimate is going to be, that how well it represents the population. So this is what you need to think about here. So all of these figures that we're coming up with are estimates to what the values might be in the population. Right, so let me just read through what I've written here. Can't quite remember now, but this is what I'm trying to get to, is this point about confidence intervals, spread of data, estimates, certainty, and this helps us draw conclusions from the results that we've got. So please don't just go straight for the p-value. Look at the spread of the data. Look in particular at confidence intervals. Confidence intervals are a calculation based on standard errors, and you can all do these yourself if you're interested in them. I used to share an office with Janet Wilson, and every now and then we would send each other a standard error, and then we would both sit and try and work it out and what the confidence interval would be from certain studies where they haven't reported them, and you get a good idea of what was going on. So here we are again, estimates and confidence intervals. I'll get onto this in a bit, and hypothesis testing. So yeah, this is the sort of thing Janet and I used to do, is if someone had produced standard deviations only and a mean, then we would go, well, what's the confidence interval? So you can calculate it. The standard, you can calculate the standard error from the standard deviation and what the population size is. The smaller the standard error, the higher the precision over your estimate. And of course, the more patients, the more observations you have, the more values that you have, the tighter the spread, the more precise the estimate is of what you're trying to measure. So this is all quite broad at the minute, and I hope you're following us. So confidence intervals, you can calculate from 1.96 times the standard error. That's used for a 95% confidence interval. Sometimes it's not quite exactly that, but you're not going to be far off by measuring that. So confidence intervals are important because you can look at the breadth of them, the narrowness of them, and that will give you a really good idea of what sort of strength of conclusion you can draw from a study. Some of you will be aware that if I've got a slide on this in a minute, but let's say you're looking at a difference between means between two. Let's say you've got a treatment group and a placebo group, and you want to look at the difference between the means. Then if a confidence interval crosses 0, then you draw the conclusion that there's no significant difference between the two arms. So that's often where people use confidence intervals the most, is the confidence interval for the difference in means crossing 0. But you can look at them in a lot more detail and actually look at what the means are, what you're measuring, and how tight that confidence interval is. This is something that Janet sent me as well, which is it is splitting hairs, but if you're interested in this sort of thing, you know, we all think that a 95% confidence interval is the chance that the true mean lies between those boundaries, but actually, as this observer's pointing out, it's not. It's that it's the if you reproduce the study lots and lots of times, then there'd be 95% chance of it lying between them. It's slightly different, but I wouldn't worry about this for your station. So just as an example, then let's say you're measuring hemoglobin. Everything always, whenever you're reading any books about medical statistics, they're always measuring hemoglobin or blood pressure change. No one ever looks at anything related to ENT. But look, you know, someone gives you a population mean of a hemoglobin and a standard deviation, then you can very easily calculate the confidence interval yourself by looking at the standard error and 1.96 times that standard error. So that gives you your confidence interval. That's how you do it. Comparing the means, we've sort of discussed as well. This is important that the confidence intervals assumes normality in the distributions. So let's go on to something. Let's not worry too much about confidence intervals, other than I would definitely report the confidence intervals if you're coming to present this in your station. I think if someone turns up and mentions their interpretation of the confidence intervals, I'd be really impressed. Is the confidence intervals of the difference between the means crossing zero? Is it not? How tight is it? What's my interpretation of the spread of the confidence intervals? I'd be really impressed with that. That would impress me far more than someone who just looks at the p-value and quotes me the p-value. But let's move on to p-values. Everyone wants to use them. Everyone's obsessed with p-values. What do they actually mean? Well, this is what they're here for. They're for hypothesis testing. All right. So let's say you've got an intervention on a group of patients. You want to know whether your intervention is any better than the comparator. The comparator might be the standard treatment, or it might be placebo. Doesn't really matter. But your null hypothesis is always that there's no difference, that the two arms that you've got are going to offer the same outcome to the participants. The alternative hypothesis is that there is a difference. And usually this is set out in a two-tailed manner. So you don't say it's going to be better or it's going to be worse. It's just that there is a difference. That's all you're trying to say. So there we go. That's what I've just said. Probability is a number of times an event would occur if repeated a large number of times. So we all know, we can all work out what the probability of tossing a coin is in terms of heads and tails. We can all work out what the probability of throwing 3 heads in a row is. This is probability, okay? So what the p-value means, this is the significance level. So arbitrarily, most of us will discuss the significance level as being 0.05. If you're doing a really important clinical trial, let's say you're running a big COVID vaccine trial, you're not going to set the p-value at 0.05. You're going to set it a lot lower than that because it's so important. You want to make sure that you've drawn the correct conclusion. So the p-value, let's say, what does it mean? Well, it's the probability of accepting your alternative hypothesis when the null hypothesis is true. So that means you've accepted that there's a difference between the two arms. Let's say we're discussing two arms. We've accepted that there's a difference between the two arms when actually in the whole population, there isn't. And that's a chance. Okay, we accept that. We say, well, how important is this question? What's the impact of it? most of the time we're setting that risk as that significance level as 1 in 20. So there's a 1 in 20 chance that we say that there's a difference when actually there isn't. The lower the p-value, the less likely we are to make an error, the less likely we are to accept that there's a difference when actually in the population, in reality, one doesn't exist. That's why if it's a really important clinical question, you're going to drop your significance level right down to help draw your conclusion. So here's this in a diagram. P-values are a continuum. There's nothing magic about the 0.05. It's just an arbitrary cutoff that we've set for significance. And that risk there is 1 in 20 of accepting a difference when actually one doesn't happen. The lower your p-value down, the more confident you can be. But so report your p-values, all right? Don't just say they're less than 0.05 or less than 0.01. When they get down to 0.001, then yeah, a lot of journals just say less than that. But here's the point, and please don't make this mistake. 0.05 isn't a magic cutoff. You don't suddenly, if a clinical question was repeated twice, and one group says that p-value is 0.051 and the other one says it's 0.049, you're not going to be left in a quandary. The strength of the difference is roughly the same. Something hasn't dramatically changed either side of 0.05. It's still up to us as readers to interpret, or up to the researchers reporting it to interpret what that means. You wouldn't, and this is, and I do hear people saying this, let's say they saw a value of 0.054. They say, oh, if we'd just done some more samples, we'd have got it below 0.05. That's not the way to look at it. This all needs to set out right from the outset. So what happens if you, if you see in a non-significant p-value, so it's over 0.05, what does that mean? And if you get a small observational case series study, that's the problem. You may well see this. And what does a non-significant p-value mean? Well, it might mean that there's no real effect, or it might mean that there's a real effect, but we haven't identified it because the sample's too small. So that's what you call a type 2 error, where you've said there's no intervention effect, when actually the reality is that there may be. It's just that you've not picked it up. And the power of the study, the statistical power of the study, is important if you don't want to get type 2 errors. All right, so non-significance doesn't mean no difference. You have to look at whether the trial's well powered to pick these up. So, and this brings us on to sample size calculations, and I would mention these if you, in your station. And I think it's you need more than just to report whether a sample size calculation has been done. I think you need to have some idea of what they mean. And look, sample sizes are at best an estimate of how big a study needs to be to have the power to pick up changes when they may exist. That's all it really is. So you tend to use data that's already out there. You might use pilot data. You might use other trials that have been published. And what we want to do a sample size calculation is all the spread of data that I've just been telling you about. You'll want the standard deviation. And you'll want an idea of what the clinically important effect is that you're looking at to help you set these out. So why do we do sample size calculations? Well, if we have a too small a study, then we lack precision. We might miss clinically important effects because it's not done. And that is unethical, because we've run a trial, we've recruited patients, and we never stood a chance of finding an outcome because it was too small. On the other hand, if you have a study that's far too big, you're wasting valuable resources, time, money. You're putting participants through through a trial that's too big. So again, that's potentially unethical. So you're trying to balance this so that you've recruited enough participants that you can answer the question well enough to meet the clinical question that's then going to impact practice. Won't go into this in too much detail, but this is the sort of thing you need. So to set it out, you set the significance level. So the significance level is what we've said, the chance of a type 1 error, 0.05. What's the chances of you accepting that there's a difference when there isn't? The power level is the type 2 risk. You then need your standard deviation, and then you need this idea of what the minimum clinically important difference is that you're interested in. And that may not be defined. It may be defined like we said there was with SNOT-22, but it may not be. And if it's not defined, you've got to go out and do some work with clinicians and with patients and find out what that minimum difference might be. So as I've said, SNOT-22, 9 points. If you, those of you who are interested in swallowing, dysphagia, the MD Anderson dysphagia inventory is a commonly used questionnaire that we use in head and neck cancer. That's had a lot of research behind it, and 10 points on that. It's scored out of 100. 10 points is seen as a clinically important difference. That's interesting. I don't know. There may not be many of you who've read these, but there's two really important head and neck cancer trials that have come out in the last few years, looking at robotic surgery compared to radiotherapy and chemotherapy. And the second one was looking at the swallowing afterwards, and they showed a statistically significant benefit with radiotherapy compared to robotic surgery in terms of the MD Anderson, but they couldn't conclude that there was any clinical difference because the difference that they found was not 10 points. So, and that was really interesting to see. You know, reporting a significant difference, but not a clinically significant difference. That's why these things are helpful. This is the type of thing you can use. This is a nomogram from Douglas Altman's book, and you can use it. You'll find all sorts of packages online that can do this for you. Why is this interesting? Why is it interesting for some of you there? Well, some of you may come up with your own research questions. You may say, I'm interested in looking at this. I wonder whether I can do it. And actually, if you've got some idea of what the size of the trial needs to be, you can get an idea yourself of whether it's feasible. If you want to look at a question in a really rare group of patients, and you plot it out and say, well, I need 400 patients and my clinic only sees 20 of them every year, then you know you're going to find it difficult to do that. That's why knowing how to do this is helpful. But this nomogram here is, you've got the standardized difference on the left. You've got the significance level there with 0.01 or 0.05 in the middle, and then you've got the statistical power. Standardized difference is the same as your effect size. That's the clinical difference divided by the standard deviation. Effect sizes are really useful as well, because they're quite simple to look at. What's the clinical difference, i.e. what's the difference in means, divided by the standard deviation? And that is the effect. That's the same as Cohen's effect size. Some of you may have heard about large, medium, small effect sizes. You need bigger samples, bigger trials to pick up small differences. That's the take-home message from there. We're sort of getting there now. Right. So why do you want to understand this? Well, actually, I think all of us as medics have got research questions. We may want to use this to help it. But I think for the purpose of your interview coming up, some idea of why sample sizes are important, some idea of, if it's a well-conducted clinical trial, it will state the significance level, the power, the minimum clinically important difference, and hopefully now you'll understand how it's put together and what that means. This isn't the end of my talk just yet, but look at the conclusions as well, because well-written conclusions should be nice and succinct, they should reflect the results that have been presented. They shouldn't bring up anything new, and they shouldn't be opinion-based. You know, they need to be factual. I pull people up in oral presentations where they present a pile of results, and then their conclusion end slide is a series of opinions. Your conclusions have to reflect what the results you've done, all right? And if it's a poorly conducted paper, just have a look at the conclusions and see whether you think it is a true reflection of what the results show, rather than, you know, they may choose not to have spoken about their primary outcome results. They may choose to explain why the result was as it was rather than as they expected. So just look at it very objectively. The discussions are there to put your opinions across. The conclusions aren't. So let's just get, so this is how I would set out things for your interview station. Do it in a very systematic manner. Start out by saying what the title is, who's published. You don't need to give every author, but just say where the group is from, where was it published? Is it a single center study? Is it a multi-center study? What was it published in? That's important. You know, is this a high impact factor peer-reviewed journal? What's the purpose and the nature of the study? You know, what was the population they were looking at? What was the type of the study design? Then summarize the methodologies as I've suggested to you. Summarize the results as I've suggested, but concentrate on the primary outcome results. Make sure that you demonstrate to the interviewer that you understand what a primary outcome is and whether they've reported it as such. Yes, report the secondary outcomes if they are important, but concentrate on the primary outcome. Then look at the strengths and weaknesses of the study. This is a really important. Give a balanced view, all right? And then at the end, give your opinion on what you think the value of the study is and what the impact of it's likely to be. And that will do you. If you all do that, you're going to be absolutely fine in this station. What do we mean by strengths and weaknesses? Well, I'm not going to go through them all, but you know, is this well conducted? Is it well designed? Let's go right back to the second slide that we've said. Is the study population reflective of the target population? i.e., are the conclusions from the study generalizable to your clinical practice? Can you take those results and put them into your practice or not? Is there a problem with the population? This is often one of the main issues with randomized clinical trials, that they've had to be so tight in their design that they sometimes miss out some important patients that we would normally be treating. So that may be the weaknesses. You may come across a paper that's too small a population, the type 2 error that we've discussed. Sometimes when there's placebos been used, people tend not to explore the effect of the placebo or mention that too much, but it is important. But look, there's lots of things you can think about in terms of strengths and weaknesses. And of course, if you read the full paper that you're given, and I assume that you're given it in advance, they should discuss this in the discussions as well. So for this type of station, there shouldn't be too much that you actually need to do other than really read through it all critically and put it together in a nice summary. A well-conducted trial, well written, should put their strengths and weaknesses in there as well. Right, and then I think a nice way to finish is just give your thoughts. You know, is the study going to influence your practice? What do you think the value of it is? What do you think the potential impact of the study is? That's what we're all trying to design. We're all trying to design a study that's going to impact our clinical practice, and it's very difficult to do. What statistical revision books would you recommend? So there's keep it simple. There was a BMJ one, wasn't there, by Tricia Greenhoff, that used to be in existence. That was good. The one I always go to is a bit bigger. It's the one that I've taken that picture of the nomogram from. Douglas Altman's Practical Statistics for Medical Research is brilliant. It's so clearly written. Douglas Altman was the sort of one of the real leaders of defining medical statistics and how we use things. It's a great book to read. It's quite big. Most of your libraries will have it. How did it feel having your paper for the ST3 interviews? Do you know? I think it was one of my friends who I was at university with who actually chose that for the thing. I was absolutely delighted. It's all when you do these clinical trials, it's all about whether you can then influence practice. And there's no better way of influencing future practice than for all ENT trainees to have read it. It was great. What we really hope with the proton pump inhibitor paper is that our findings filter through into general practice, because I think undoubtedly GPs giving proton pump inhibitors for throat symptoms has come about because we as ENT clinicians told them to do so. So now what I'm hoping is that the likes of all you here consider how we use proton pump inhibitors, and maybe hopefully we have discouraged you from using them in an empirical manner, and hopefully that message will filter through to general practice again. But no, it was great. How much time would you aim to complete the presentation of the critical appraisal can anyone tell me how long you think you'd have for the station? I'm not quite sure.
We have 10 minutes.
Pardon?
10 minutes.
10 minutes. So it's quite hard to talk for much more than 5 minutes, isn't it, on critical appraisal when you're trying to remember the paper and trying to set it out. I think you'd be far better making sure you've not missed any big chunks of your presentation than you are to ramble on and on and on. Are you allowed to take in any prompts to help you with this, or is this purely from memory in terms of...
You get the paper.
Pardon?
You get the paper in the station.
Yeah, but then you've got to remember, don't you? You've got to remember how you've put your critical appraisal together. So you're going to need to give yourself a strategy so that you don't forget parts. I've seen that done as well. I've seen people miss out the critique of the methods and move straight on to their opinion of this is very easy to do. You may miss the actual objective element of describing and summarizing it to get on to telling the person what you think about the paper. So don't do that. If you allow the paper, if you allow the paper in front of you, use the headings of the sections of the paper to help jog your memory about what you want to say about each element. What type of studies might be found to be criticized? Is it small number of patient studies, or is it large numbers? I think what I said from the outset is, I think you'll get one of... If I was running this station, I would do one of two things. I would either give you a well-conducted clinical trial that you're not really going to be able to criticize, so that it gives you the chance of summarizing it, or I would give you a small observational case series in which maybe somebody's overinflated the findings of the results and overinflated the conclusion, and see whether you could explain why that's the case. I would do one of the two, but yeah, generally it's the problem with poorly conducted studies. I've got no problem at all with somebody publishing an observational case series if the conclusions are appropriate for what they've done. If you sit there and say, look, we've looked at this in a small number of patients, this is what we found, this is what we think it might mean, end of story, fine. But if you get someone producing a small number of patients and then making a wildly ambitious conclusion for it, or stating that there's no difference whatsoever when the sample size is too small, that's when I would be critical. To the question of how to influence practice, what particular aspects of practice, primary care, clinical, ward, Anywhere else I'm missing? No, look, it's just the whole, just think of what our practice is. You know, proton pump inhibitors happen to be an outpatient practice, but you might get a paper that looks at an emergency intervention or the effects of surgery. You know, and of course, what you're trying to influence there is very different. So let me give you an example then. So we're hoping to publicize Natina. That's a big randomized trial of tonsillectomy in adults versus conservative management. Who are we trying to influence there? Well, actually, we're trying to influence commissioners of health services so that they recognize the merit of tonsillectomy. We're trying to get that message through to general practice so that we have less variation in how patients are referred for tonsillectomy. And we're also trying to influence clinicians so that they understand more about what the evidence is behind it. So all aspects really. But if it's a specific surgical trial looking at one nuance of a surgical method over another, then maybe you're just trying to impact ENT clinicians.